Floor is all yours.
Shukran. Thank you, Sarah. Let me just see if I can share my screen. Can I, all right. All right, you guys can see my screen, I hope. All right. Well, thank you, Sarah, for the introduction, but for the um, purpose of saving time, let me start. I wouldn't consider myself a subject matter expert, but I've seen the area. I've seen cholera a long time ago. But anyhow, so this is a famous picture of um, acute watery diarrhea, and the difference in the left between gastroenteritis, which can look green, and this is mostly in viral gastroenteritis versus cholera, which is, the famous description is a rice water cholera, especially in what they call it, cholera gravis. So all of you are familiar with that. But I think just before we start the diagnosis, just a quick look about the differential diagnosis, because not all diarrhea is cholera, but cholera is important because the volume of diarrhea, the volume of loss, and the composition of the stool itself is a little bit different in cholera compared to the others. So acute watery diarrhea, the common pathogens, E. coli is mostly number one, specifically the enterotoxigenic E. coli. And then Vibrio cholerae, norovirus is virus, so it's by far more common, but vomiting in norovirus is more like a prominent feature. And then you have the Campylobacter and Salmonella. Erymonas, which is a kind of a bacteria which love water. This is hence the name Erymonas. Hydrophilia, the second part of it. And then aggregative E. coli. And then there is bacteroid, which also secrete a toxin. Most of the first category, they are just watery diarrhea, and then the bloody diarrhea is a Shigella, Campylobacter. Also, you notice Campylobacter can come in both, and then an enteroinvasive E. coli, and then enterohemorrhagic E. coli, and non-typhoidal Salmonella, and Intamiba and Schistosoma mansoni. These can also cause acute bloody diarrhea. The difference between the E. coli, enteroinvasive, and enterohemorrhagic, which cause bloody diarrhea, and enterotoxigenic is not clinical, is lab based. And then similarly in children, acute watery diarrhea can be caused by enterotoxigenic E. coli, but rotavirus is probably the most common, and Vibrio cholerae, and then cryptosporidium in different categories, especially HIV and then norovirus, and then the invasive, which is bloody, Shigella, and the others. So, the diagnosis of cholera, it has two ways looking at it. If you have epidemiological kind of perspective, is if you have outbreak of cholera which is announced, then it's easy, because every patient comes with acute watery diarrhea, you think of it cholera until proof otherwise. Assuming that that if the patient comes with bloody diarrhea, that is probably not cholera. That's probably other things, because the common denominator in all these um, outbreaks of water is access to water and sanitation. So it can cause other things. So just to be um, careful about that. Stool culture is important. and then there's selective media and stool or rectal swab. But it's not important for the diagnosis as a clinician, as when you are sitting in a clinic or a center for cholera, then you are not going to do stool culture for everyone. But I have to say, stool culture is extremely important in a setting of outbreak because of the antibiotic susceptibility. You want to do antibiotic susceptibility because we'll come to that in when we discuss antibiotics. But you have to have at least a couple of samples where you kind of detect if this is which antibiotic is susceptible and which is not, because it's changing. And then rapid testing is probably important for individual cases. Rapid antigen detection, molecular testing is mostly, as far as I know, is not commercially available. And then dark field microscopy. Dark field microscopy is interesting because the sensitivity is not high, but the specificity is great because if you see it, then it's probably it. And Vibrio cholerae is famous that is motile bacteria. So the description is a shooting star. So you see it just crossing the dark field quickly, and sometimes you can add some antibodies or something like that just to decrease the motility of the Vibrio cholerae. Dark field microscopy is great because it's cheap. So if you are sitting in a place where you don't have a lot of resources and you could have access to microscopy, so dark field is great in that setting. So again, I repeat, epidemiologically, you don't need to do all that kind of things. It's mostly for clinical, and stool culture is mostly for detecting the susceptibility of antibiotics. So the major part in the treatment and the cornerstone is the rehydration. That is a magic bullet. As we know, most of the time, the patient, the majority of the patient, they have mild symptoms, sometimes no symptoms. So you don't see those patients. You see the people who come with dehydration. And for the dehydration, it's important to define from the beginning if there is no dehydration, some dehydration, which is where anywhere between 5 to 10% loss in the weight, and then severe dehydration more than 10%. This is no dehydration, then the description is clear. Between some dehydration, severe dehydration, there is a little bit of overlap in sunken eyes and thirsty and all that kind of thing. But obviously, when the people get severe dehydration to the shock, when the estimated fluid deficit is more than 100 ml per kg, so you think about somebody who's 60 average, 100 ml is 6,006 liters. So this probably lost equal to his blood volume. So these are serious. My clinical expertise is, and the bigger mistake always people complain about that there is underestimation of the patient who had specifically cholera compared to other acute watery diarrhea. So you tend to do less than more. I think if you have any doubt, clinically speaking, move to the second category. If you think the patient, I see no dehydration, some dehydration, move to the some dehydration. And if you think the patient is in between some dehydration, 10% or more than 10%, move to severe dehydration and then reassess, because the reassessment is also very important in treatment of diarrhea. So these are the diagram. Here is the assessment of dehydration, and then here is the maintenance of fluid after you replace the deficit. And the deficit is, by the definition, you start on the top of the algorithm where you assess the volume status. If there is no hydration, then you go to oral hydration with ORS. And then if there is some dehydration, then you correct the fluid deficit. They pick 75 ml because we said the some dehydration is anywhere between 50 to 100 ml per kg loss. So you try to replace that by 4 hours. If the patient had any of these following, like you saw the patient, you said, oh, this is some dehydration, and then you start the IV fluid replacement, and then if you find the patient still have profound ongoing stool loss, or vomiting, or you couldn't really find a vein or something like that, then you have to to move to severe dehydration. And I'm not sure if the people still do the interosseous. Um, and then severe dehydration, there is differentiated between children less than 1 year and children more than one year. Um, and I have just to say that this is mostly for children who have acute um, dehydration without malnutrition, because with malnutrition it's a little bit more complex. You are worried about refeeding syndrome, you are worried about electrolyte disturbance, you are worried about many things. So then this is the approach to fluid management with adult with hypovolemia. If the patient had severe hypovolemia, no hypovolemia, ORS, and then you reassess. And if they have severe hypovolemia, you go with IV fluid, and you start a bit the starting there. You give the majority. You wanted to give over 24 hours, but you have to give the 30 ml, the bolus over the 30 minutes, and then you relax a little bit, and then you do the rest over 4 hours. And then you reassess the patient continuously. It's very tricky when you see the patient in between severe dehydration or severe hypovolemia or moderate, because sometimes if you delay, even the IV catheter might be very hard to replace. So you have to use clinical judgment and adjust this to your the area where you are seeing the patient. If you have big volume of patients and you can't really do the triage efficiently, then you just move towards placing IV fluid, and then reassess. In any case, you probably would know better than me in that situation. This is a famous cholera cut. The major part of these treatment centers, and this is again from uh, it became famous during the Haiti outbreak in 2010. It will allow you to assess the volume loss because you have a pocket and you can see. So, if you are worried like about the patient telling you how much he is losing fluid or how much he is passing his stool, then this is great because you can see um, the amount of fluid. I mean, obviously, you have to also use judgment, because if the patient is vomiting, you might not calculate these. And this is a little bit of guidance for how much fluid, especially for patients who are younger group. Those are the patients you will have to be a little bit worried about it. By the way, I'm not a pediatrician, so if there is a pediatrician in the audience, I would be great, because they are dealing more with kids. This is a study published in the early days, just comparison between cholera and E. coli enterotoxigenic and rotavirus, composition of both the purging rate and the sodium concentration. Potassium seems in all these causes of diarrhea is not very big difference between them, but you could see the purging rate in cholera is 60 ml per kg per hour versus 40 in E. coli and 31 in rotavirus. So almost double the volume in cholera. And the sodium concentration in the cholera is kind of also high, like 90 compared to 50 for in heterotoxigenic E. coli and 37 in rotavirus. And this is probably has something to do with the enterotoxin. This has become important because if you use in intravenous fluid, if you use the Ranger lactate, it had more potassium than the normal saline, which doesn't have no potassium. Um, and similarly, there is a local made normal saline. It's called cholera saline. It's mostly in Asia used, and I'm not sure of the availability, but it's called DACA solution, and had high concentration of sodium. You could see it in the middle of the table, and it's 13 compared to 4 in Ranger like that. So this is great if you have that. And then there is rice-based ORS as compared to the ORS, the WHO kind of ORS. And then there is some advice down about homemade ORS where even if you don't have it, you can use it. Just mind you, again, children with severe malnutrition, the ORS, you double the water, the amount of water just to dilute it, so they don't get the whole thing, and then they have. So the antibiotic therapy, again, the user rationale, it shortened the duration of the diarrhea to 48 hours roughly, and it reduced the volume loss up to 50%, and then just shortened the duration of stool shedding from anywhere from 5 days to 1 to 2 days. And the common antimicrobial used is doxycycline, azithromycin, and ciprofloxacin. Um, Ciprofloxacin, it seems like there is a lot of susceptibility issues and resistance and all that kind of thing. So you remain between azithromycin and doxycycline. Azithromycin is 1 gram single dose, and doxycycline is 300 milligrams single dose. Now, the difference between this is why doing the culture is even just for epidemiological surveillance and to know what kind of Vibrio cholerae leading your outbreak is important, because it's a single dose, and the effect is not eradication of the infection. The effect is shortening the duration of diarrhea to 48 hours. But as you know, the absolute number is missing here. So if the patient usually diarrhea is 5 days, if you give them antibiotic, then it will be 2 days and a half. But you won't know, because the incubation period and the symptoms is very variable between the people. And similarly, reduce the volume of fluid loss by 50%, you won't know the way you are starting if the patient is going to lose, how much he will lose. And patient can lose 2 liters per hour. Some patients come with deficit of above 10 liters. So it's hard to know. So this is why doing the susceptibility is very important. 2 years ago, there was a small outbreak in northern, in Western Kenya. And when, traditionally people give azithromycin because the reports, as you could see here, there is a rare report of macrolide resistance. Funny enough, that's outbreak was resistant to azithromycin and was susceptible to doxycycline. We wouldn't have known if we don't do the stool culture, because everybody will just give the people azithromycin. Now, the antibiotic is not used for mass prophylaxis because it doesn't kill all the bacteria, but it's used mostly for severe dehydration. And there is a discussion about moderate dehydration, especially in children. Now, we were taught that doxycycline, Cipro, and azithromycin, these drugs you don't give to pediatric group, but especially with ciprofloxacin, things are changing, and even with azithromycin and doxycycline. Remember, this is a single dose. So for children, single dose doxycycline is unlikely to cause dental staining or severe adverse effects. So it's kind of really risk versus benefit kind of discussion. Now, where these where is the rationale why people say that that antimicrobial drugs could treat? A meta-analysis done, I think it's also in 2014, shortly after the outbreak of Haiti in 2010, and it was randomized controlled trial or quasi randomized controlled trial. They put them all together, and then they come with recommendation. They say they actually look for all RCTs which compare antimicrobial to placebo or no treatment and different antimicrobial head to head, and then the different dosing and different schedule. So total was 39 studies between RCT and quasi randomized control trial, up to 4,000 participants, and they basically came up with the same ideas which we are using now, that the result of antimicrobial therapy shortened the duration of treatment by about 1.5 days, and then reduce the total stool volume by around 50%, reduce the amount of rehydration fluid required by 40%, and then the main duration of physical exertion was also excretion, shedding was reduced. So, theoretically, this might reduce your outbreak, but that is still yet to be defined. And then I find this perspective piece is very good. It's in New England Journal of Medicine, is again published in 2011, and you could see that they spoke about the Haiti, but it's basically they advocate here in because WHO say antibiotic only for severe cholera. These people they advocate for moderate and severe. It's actually from the International Center of Diarrheal Disease Research in Bangladesh. Mind you that in South Asia, certain countries have endemic out. So most of the studies coming from there. And then finally, just one important thing about antibiotic. When people always say antibiotic, they think it's a magic bullet. You give the people antibiotic and forget about it. It is not that. I think historically, the fear of saying, oh, antibiotic for cholera, although it can reduce even the historically people are worried that once you say antibiotic, people forget about hydration. Again, I have to say hydration remains the cornerstone of management of severe cholera. And antibiotics can help you, but the focus should be rehydration. Similarly, for prevention, there is available oral vaccines qualified by the WHO. The first vaccine, if you call that is basically the one available, because the second one, which is I think the production was ceased in 2023. Most of these vaccines is 2 doses. The exception is with the vaccine shortages and all that kind of thing. And it seems that the single vaccine dose give you a little bit of protection, but anyhow. So just to finish the talk, similarly, if the fluid management is the cornerstone of treatment of cholera, it's not the oral vaccine is a infrastructure, even thinking about points of safe water in a complex humanitarian emergencies or war situation, it remains more important than the vaccine or the treatment. Prevention is always important, but also prevention the causes of the whole thing. Now, just to finalize, WHO had very nice website for cholera, and I didn't try it recently, but I'm not sure if it's even available or not. But they have these kits, which is kind of designed kits for situation like outbreaks, where they have central reference kit, and it had treatment for 100 patients, and there is 80 severe cases, 20 moderate cases, and then peripheral kit, like if you're not in, and then there is community kit, and then they have lab kit and all that kind of thing. And it's you can check their website. I think it was updated, these kits, in 2022, I believe, but it's a nice website, and theoretically speaking, you could order actually the WHO through this website. It's about this website. If it is functional, there is a kit. There is a tool for calculating how much kits you would like to order. But I honestly did not try here. And then if you have any questions, we can either I don't know, Sarah. So I'll stop sharing and thank you guys for giving me this opportunity.
Well, thank you so much, Dr. Luaie, for this informative session. Dr. Luaie, I think he is not a subject matter expert. Actually, he is the associate professor of infectious diseases and have worked in both internal medicine and infectious diseases. He made his internal medicine residency in New York and the fellowship at Dartmouth. And he worked at MSF in Africa, Darfur, also South Sudan. And he received Queen Elizabeth Medal for his contribution in Ebola outbreak. So it is honors to have you, Dr. Professor Rai, and it was really informative talk. We are really happy to have you. So thanks. Now I will move with Ahmed to see if there is any questions. There is some question at the chat. So I can.
Hello everyone, and thank you again, Dr. Luaie, for your amazing presentation. There is a question in the chat from Roa Ahmed, and yeah, such as lobramide in treating cholera.
And I think Ahmed Atayib answered. I think he's right. You know, it's a toxin to get out. So most of the bacteria infectious causes, not only cholera. I think you try to avoid lopramide, you know, C. diff colitis, Shigella, cholera. Most of these you don't want that. You want the shedding to continue and the patient get rid of the bacteria. So thank you for the question now. Huh?
Any more questions? No more questions?
No. So if
If,
anyone
if
have
you
any
are,
question, feel free to text it in the chat
if
or just raise your hand.
Now we will move.
if you allow me, Muhammad, Sarah, if you allow me,
Yeah, go ahead, Ahmed.
a question for Dr. Kailani. Thank you very much, Dr. Kailani, for the informative and comprehensive presentation on the diagnosis and management of cholera. So, as a person from the field, we have this observation of a number of patients. They have hypokalemia, and we always see patients with hypokalemia and hypokalemia. Maybe this is related to the management itself and or mismanagement of the patient and decreased hydration. But when the medical care providers try to manage this hypokalemia, I think they always faced by the shortage of the potassium chloride and the drug options to treat this. So, are there any maybe we can just do some locally made recipes or to address this issue when we are talking at the field level. It's very difficult to chloride and other drug alternatives. to treat this hypokalemia. So how it could be addressed?
So I mean I agree. This is very complex situation because potassium is one is not available as you mentioned. To even the potassium replacement is very tricky because if you overshoot it, the patient. Sorry, I have a unhappy kid here, but anyhow, so the potassium, um, and because I've been in this situation multiple times. Funny because I worked in Congo a long time ago, and in cholera outbreak, we didn't even think about potassium because it's not possible because you don't have lab um to lab, then it will take a while for the result to come back. And but I have to say potassium is one of the light to replace. And then you have the issues of the lab um, and the rapid test is always even in the best centers, like if you do VBG, ABG, and then you see the electrolyte with ABG, because that is probably the fastest, is not. So this is why, and I think and honestly, Ahmed, I don't know if it's available, but that fluid, they call it cholera saline. I think it's. I mean, you could see how these people they thought about. Oh, this is why we need to use this because it had more potassium even than the ringer lactate, which relatively normal saline does not have any potassium. And so this is why it's important to think about either like using ringer lactate or trying to figure out how to get these um, cholera saline. And honestly, I apologize. I don't have idea how to recruit both of these, but I think that will be the best thing to reduce it. You also brought something important. Most of these patients are vomiting, so this is why ORS sometimes is hard, and even antibiotic orally is hard. So the recommendation is to wait until the vomit kind of subside, and hopefully the vomit subside by. Um, when you look at the symptoms of cholera, people speak about leg cramp. Leg cramp is not the cholera; it's a hypokalemia. So most of this is hard, and I find um definitely the severe hydration and the shock, but electrolyte disturbance is extremely um, problematic. Um, Lastly, I think if I were in the field and I have no access to or lab to check the potassium, I just ask the patient, focus on food with a lot of potassium, banana, guava, and that kind of thing. And by the way, guava had more potassium than banana. But anyhow, you know, uh, sorry, don't have a good answer for you, huh?
No, thank you very much. This is actually field-based explanation. And we also advise patients to eat banana and jawar. But it would be a great solution if we have something to, just like the DACA solution, as you mentioned, or any cholera saline. It will be of a great help.
Okay, we can take one last comment from the chat and then we can go with Ahmed Izzeddin presentation. Okay, it's from Ahmed Al-Taib. He said why there are no protocol to SAM with cholera because it was big problem to us during the last outbreak.
I think I don't know honestly why there is no protocol, but if there is no, maybe we should just, all the people here sit together and write. It's not complex, to be honest. These protocols are not complex. We I will leave this to Sarah and um, but you guys, if there is no, let's make it, you know.
Yes, it is a point to work at. Uh, we we have some have been working to intervene in the cholera outbreak here in Costi. Um, and that's why we get this initiative of hosting ECHO for diarrheal disease to raise the awareness of people about this important matter. So we will discuss this issue, inshallah, and update you.
Yeah, cool. And Anwar is saying like gongolese and tomato and dates. I think these are all good. I think short of like lab based or evidence based or resource rich, you just do everything you can. And then there is question about the first aid of patient before arriving to the hospital. I think this is when they made these they call it rehydration like centers where people can get like access to ORS, because I think just hydration before other people come to the before even if you are in the triage in the hospital and you are waiting in the center or wherever you are working, make sure that even in the triage there is always ORS for these people before getting inside, because you don't want the patient to be waiting for you. And just to Sarah point, community engagement is important because you want to give the patient, you want to give the people that this is a problem you can participate in, the to be passive waiting for somebody to come and magically treat them. You want them to have the just like diarrhea hydration, because remember and I'm not sure if this is still mild concept, but the issue was like, oh, people, I drink, I vomit, or I drink, I have diarrhea, so I should not drink. So this is the role of all of us as physician, just like, even if you are vomiting, just glaze or whatever.
And I would like to thank Ahmed for raising the point of Sam with cholera, and I can foresee that this could be really is the prevalence of malnutrition in Sudan is huge. We're having a session of managing complicated cases as part of this series, and I think maybe getting a pediatrician also at that session, I think would be helpful, right, Dr. Lai? What do you think? If you can recruit a pediatrician, maybe even from Sudan, Ahmed Azzuddin, you might be knowing people from there. If you can get someone, who is expert.
I'm happy to do that, Ahmed Al Mahal. I
Okay.
don't know a lot of pediatrician, but I think specifically for guidelines and in cholera, the opinion of the field is by far the most important, because you don't want somebody like me who is not in the field and I don't know what is available, what is not. You want somebody like Ahmed Izzeddin who are there and they know what is available, what is not. Team approach, because like you just so pediatrician, I think it's extremely important. And I'm hoping at the end of, as Sarah said, at the end of these lectures, if we can like just get everybody and just try to put stuff together and then come up with detailed, locally adjusted and feasible for the field teams to address these issues. I have to say I'm a little bit old, and when we graduated from medical school in 2001, the idea was medicine is we have to adjust the life of our communities to the medicine. Actual answer is you adjust the medicine to the community, not the opposite. Because if you are waiting for the community to be adjusted to the medicine, I waited for 20 years now. So I'm just saying, you know, locally made solutions, and I think many other countries who had similar problem like us, they find their own solutions. But waiting for you know, anyhow, sorry, this is